Hi everybody, this is a short tutorial for the acute medicine students at the MBBS Year 4. This is a short tutorial on the early clinical management of a common presentation to the emergency room and us on the acute take is the early clinical management of acute GI bleeding. So what am I going to try and do? Well, I'm going to try and tell you what it is you need to know in a relatively short tutorial. I'm going to present to you the summary consensus guidelines on acute upper GI bleed from the Society of Acute Medicine, British Society of Gastroenterologists, Royal College of Physicians and Association of Upper GI Surgeons. I'm going to summarise the evidence, good and bad, and of course if you have any questions, as I said throughout the tutorial series, then please don't hesitate to email me at my university email address. So why does this matter? Well, as you can see, looking at the age standardized mortality ratios that are alcohol specific, you can see that actually from 2001 to 2017 we have made very little progress with regards to alcohol specific deaths. And indeed, looking at 215 to 2017 data, the trajectory is on the rise again. So whether we like it or not, alcohol-specific deaths and alcohol-related problems are going to be a mainstay for us, those in acute medicine and gastroenterology and hepatology. When we look at the alcohol-specific death rates, again 2001 and 2017, you can see a very wide spread. In fact, almost, for those of you that are statistically minded, you'll recognise almost like a bell-shaped curve. You'll notice that the deaths are relatively similar across all age groups from 2001 to 2017. They start to incline fairly significantly at the age of 40 all the way up until the age of 75. It's really important again that when we approach these patients or when we discuss alcohol, drugs, sexuality, risk behaviours, that we keep an open-minded approach. I'll tell you a little story that I had one of my SHOs once present a patient to me who had fever of unknown origin, lymphopenia and so on, and I said to the SHO that the patient needed an HIV test, and the SHO turned around and said to me, well, why would you need one of those? She seems a nice middle class lady. Not that I'm in any way denigrating middle class ladies, but I'm sure you take my point. It's important that you approach these matters with objectivity and not any bias. So looking at our patch now, so obviously we carry a number of boroughs around us. So for example, for those of you that rotate into or have worked at Barnet, you'll notice that there are best mortality rates for overall in public health. We're in the borough of Camden, which as you can see is better than average. However, poorly performing boroughs include Tower Hamlets, Barking, Dagenham, Hackney, Lambeth, Islington, Newham, Southwark and Lewisham. When we look at admission episodes for alcohol-related conditions per 100,000, you can see that the borough of Camden is more or less plopped right in the middle at about 1,200 episodes for alcohol-related cardiovascular disease in persons per 100,000. As you can see, that's quite a lot. So, big picture, upper GI bleeding is a common medical emergency occurring in approximately 134 people per 100,000. Mortality remains stubbornly high at 10%. Alcohol-related admissions often cover multiple medical and non-medical issues. So, for example, GI bleeding may be associated with homelessness and alcohol abuse, sudden acute alcohol binge due to financial stresses, alcohol-related violence. So, for example, everything that goes from people trafficking, domestic violence, to a punch-up after a game of football and lots of lager. It's important, again, as I've stressed in other tutorials, particularly in the Principles of Acute Medicine talk, to always be mindful of domestic violence or trafficking. A really important good practice point here: we do not detox people in hospitals. We have a respectful but firm approach. We get people over the clinical signs of alcohol withdrawal, but we don't detox them. I'm sure you can imagine if we could detox ourselves in 24 hours with a couple of bags of Pabrinex, the world would be a very different place. But it's not. Obviously these patients need intensive psychological therapy, lots of safety netting, lots of planning, and lots of intense therapy in order to get over their alcohol addiction and hopefully be on the road to recovery. The slide here shows a widely approved UK upper GI bleeding bundle, which is to perform to be in 24 hours. It should be fairly self-explanatory, but it's important obviously to recognise that a patient may have had a GI bleed, resuscitate them using their new score, commencing IV crystalloids such as 0.9% saline or Hartmann solution, transfuse them if their HB is less than 70, aiming from 70 to 100. In the emergency department, when using a decision tool, we use a Glasgow Bradford score to determine whether they can potentially go home. We may treat them if they're cirrhotic or have a variceal bleed. We may give terlipressin, which is a splanchnic vasoconstrictor and will help improve the blood pressure and reduce portal flow, and antibiotics. Indeed, when dealing with cirrhosis, antibiotics are one of the few proven measures that are known to reduce mortality. Important to continue aspirin, which may surprise you a little bit, and again I'll come on to that later. Suspend all other antithrombotics or anticoagulants such as warfarin, clopidogrel, ticagrelor, and so on. You refer the patient for endoscopy to be taken within 24 hours of presentation. Review the endoscopy report afterwards. If they may have a PPI infusion known as the Hong Kong regime, also there may be a post-hemostasis antithrombotic plan. So, for example, when could we restart this patient's clopidogrel? This is a slightly more detailed care bundle for those who present to the emergency team with decompensated cirrhosis. Obviously, if you have a look closely, it's fairly self-explanatory and is easily downloadable. This was after a NC pod report in 2013 which showed vastly different outcomes for patients with cirrhosis and multiple areas of poor care, hence the development of this care bundle. I'll summarise it very briefly. You can see the investigations are at the top. It's important if the patient has ascites, we want to make sure that you do an ascitic tap and send it off to the lab to see if the patient has spontaneous bacterial peritonitis, otherwise known as SBP. Give the patient Pabrinex, make sure that you treat any infections that may exist, review and treat any hyponatremia and acute kidney injury, obviously treat GI bleeding as outlined above, look for encephalopathy, you may give the patient lactulose, consider a CT head, and making sure that we're prescribing VTE prophylaxis. So the three-stage bundle is basically R, and R. Recognition, resuscitation and risk assessment, referral for upper GI bleed, upper GI endoscopy, PPI, Pabrinex, chlordiazepam epoxide, otherwise known as Librium, and review. So R, RX and RV. RV, review for post-endoscopic treatment, alcohol specialist input, and our colleagues who work in the acute alcohol liaison team are of vital importance. So, coffee ground vomiting should be considered a presenting feature of acute upper GI bleed as well as hematemesis. In the diagram on the left, you'll notice a rather kind of black coffee ground vomit, hence where the term comes from. This is usually digested blood and is a sign of acute upper GI bleed. On the right hand side, you'll notice a rather dramatic picture of where there's a large amount of bright red vomit in the sink, and this should make you worry about a variceal bleed instead, which does require different treatment, especially antibiotics. Sometimes patients will present with bowel obstruction who have rather unfortunately smelling vomit, and it should always again make you consider whether this is not a bleed or whether this is a bowel obstruction, especially if there's also bilious vomiting. So causes of upper GI bleed in the United Kingdom, the most common being peptic ulcer, gastritis and erosions, and even those who have drink alcohol to excess or have chronic liver disease, the most common cause of GI bleeding is still peptic ulcer and gastritis and erosions. There's also esophagitis, and then you have varices at 8%, Mallory-Weiss tear at 3%. Mallory-Weiss tears are, if I'm going to be cliched for a moment, where a student has a rather wild night out, drinks multiple pints, gets very, very sick, and on multiple vomits that get streaks of blood. Very minor, often only streaks, and there's never a full hematemesis, and there's no coffee ground vomiting. The patients usually don't need endoscopy. Gastric cancers account for about 3%, and erosive duodenitis again accounts for about another 9%, and this is data from 2017. So follow the news. Obviously, we talk about this a lot in acute medicine. Again, it should never substitute clinical judgment. There is, however, a significant correlation between admission, national early warning score, and likely outcome of admission and death. Interestingly, the new score was more superior to the Glasgow Blatchford score, which I'll come to in a moment, in predicting mortality. Remember, scores are just scores. They should never substitute your clinical judgment. Particularly, you can see I've put the News 2 chart on there, and you'll notice that I've drawn you particular attention to consciousness, where you've got the C for confusion. Patients who have chronic liver disease may well present with GI bleeding, encephalopathy, where they can have just mild confusion all the way through to a coma. This is the Glasgow Blatchford score. This is a tool for utility in the emergency room and the acute medicine department. You can basically see that it's fairly self-explanatory. You tot up the score, and if the score is 1 or less, then the patient potentially can go home. Anything higher than a score of 2 and above will need admitting for endoscopy. So Glasgow Blatchford score is the best at predicting clinical endpoint of hospital intervention, and that hospital intervention can include blood transfusion, endoscopy, interventional radiology such as gastroduodenal artery embolization, and has a very high sensitivity at 98.6%. The accuracy of scores predict the need for OGD, or the risk of rebleeding is low. Now, previously the Glasgow Blatchford threshold was 0, but now it's 1 or less. So, i.e., those who score 1 or less, you can consider facilitated discharge. So, for example, what that means is that you think your patient will be stable at home, and they can come in a later date over the next few days for an outpatient but urgent gastroscopy. So to fluid resuscitation, we use crystalloid fluid. We never ever use 5% dextrose to resuscitate any of our patients. We use a bolus of 500 ml over less than 50 minutes, otherwise known as a fluid challenge, and the concept of this is described in the tutorial called Shock. Regularly review the news chart and titrate fluid resuscitation. We transfuse blood if the HB is less than 70 to a target of 70 to 100. Those who are prone to ischemic heart disease may need above 100. Again, it's important that we get the balance right between transfusion need and symptoms, as overly transfusing someone who doesn't need it can actually precipitate worsening of bleeding. Remember, cirrhotics can often have associated sepsis, and unlike a lot of our patients, they will often have what you have occult or quiescent sepsis. So patients won't necessarily get abdominal pain even if they have spontaneous bacterial peritonitis. So they may need involvement of the intensive care team, hepatology team, and may need vasopressor support. Hopefully some of you will have heard of the major hemorrhage pathway, and indeed if the patient continues to bleed, this should be activated. This diagram here shows you a rough scheme of the major hemorrhage pathway. So you can see when we recognise blood loss, we trigger the major blood loss protocol. You want to take baseline samples, and you also might consider giving tranexamic acid. It's primarily used in trauma, however there's no evidence of harm in giving it in gastrointestinal bleeding. Basically you have these major hemorrhage packs that come with units of O negative blood or O positive blood. So for example, O neg units in females, O positive in males, and obviously the laboratory will try and fast cross match the blood, i.e. find out what the patient's blood type is within 15 minutes. If the platelets are less than 50, which again is a common finding of thrombocytopenia in those who have chronic liver disease, it may be prudent to administer platelets, although at the moment there's no known optimal dose. You may need to give some calcium, as a rapid transfusion can cause hypocalcemia, in which case we would give IV calcium gluconate, 10 ml of 10%. So variceal bleed, which I've put in the diagram there, the closest analogy is like varicose veins of the insides, and as you can imagine, these varicose veins are prone to massive amounts of bleeding. So certainly IV antibiotics is the critical mainstay of treatment for variceal bleeding, as well of course to try and stop the bleeding endoscopically. bacterial infections are common, so even if the patient doesn't seem to have sepsis, variceal bleeding variceal bleeding mortality is improved by the administration of a broad spectrum IV antibiotics, and therefore they should not be delayed. You want to administer IV terlipressin, which gives you a 34% risk reduction of variceal bleeding for up to 5 days. But again, you want to be careful as this is quite a potent vasoconstrictor. Antiplatelet, so low-dose aspirin can be continued at presentation. Now, this is often a self-contradictory thought, but actually, if you discontinue aspirin, it can actually cause a 3 times risk of cardio and cerebrovascular events, with the majority is 7 to 10 days after stopping and the GI bleed. So what that means is that actually, even if you come in with a GI bleed, if you stop the aspirin, you're at 3 times risk of a stroke or heart attack. It always has to be a balance of risks of acute upper GI bleeding versus the thrombotic event. They may need temporary suspension, but give this some thought. Dual antiplatelet therapy, for example, for 12 months after a drug-eluting stent, or 1 month or bare metal stent. Now, this again is quite important. So this is patients who have had a stent put in, a drug-eluting stent, which is what DES stands for. Then they have to be on DAPT, or dual antiplatelet therapy, i.e. aspirin and clopidogrel, for 12 months. If you stop it in this period, there is a 40% risk of MI and in-stent thrombosis. And again, you want to discuss this with the cardiologist before making this decision. Anticoagulants, so you may be familiar in the earlier stages of your training about warfarin. We use it far less now, thankfully. We now use things like rivaroxaban, edoxaban, apixaban. Warfarin can be suspended, stopped, or reversed using vitamin K or prothrombin complex concentrate. Dabigatran is a thrombin inhibitor. Rivaroxaban, edoxaban, apixaban are factor Xa inhibitors. It's usually appropriate just to suspend them. They have relatively short half-lives. If they have severe bleeding on one of those other agents, then we'd want to discuss it with haematology. As you can see from the bottom 2 points, the Variceal agents, for example, dabigatran, are £2,400 for 2 vials, and adenexat for anti-factor Xa reversal is £11,000 per 4 vials, so not cheap at all. Endoscopy should be offered to patients with suspected acute upper GI bleeding within 24 hours of admission and presentation. May be urgent once they've stabilised. In the UK 2015 guidance for variceal bleed, endoscopy within 24 hours for all variceal bleeds, unless they're unstable, where you proceed after resuscitation. And in those sorts of situations, if the patients are unstable, it may be that they are put to sleep by my colleagues in anaesthetic, and the endoscopy is done in a theatre environment in case the patient needs an urgent laparotomy. High-risk ulcers, which is what you can see in this diagram here, should receive IV PPI. The Hong Kong regime, which I mentioned earlier, is an 80 mg bolus of omeprazole, then 8 mg per hour for 72 hours. Alternatively, you can give intermittent PPI IV or high-dose orally. So what not do we do so much? Well, we don't often do digital rectal examinations. They can be helpful in diagnosis. So, for example, if you have melena, again, or black tarry stools, again, that can be diagnostically useful and suggestive of acute upper GI bleeding. However, 55% of patients, perhaps unsurprisingly, don't like it being done. I would still advocate for it being done, though, if your patient agrees. Pre-endoscopy PPI, so this is something that used to be done a lot. We are now changing the culture, so it's done less. So there's no difference in transfusion, rebleeding, or need for surgery, or 30-day mortality, and actually giving patient lots of proton pump inhibitors prior to endoscopy may affect the endoscopic view. Sometimes we'll give a prokinetic drug like IV erythromycin prior to endoscopy, and that will basically help aid the view. So this is just a very short 20-minute tutorial on the management of acute upper GI bleeding. I hope this is useful, and again, this will be uploaded on YouTube and the PDF put onto Moodle. If you have any questions, you know my email address. With very best wishes, take care all of you. Bye bye.